Astrocytoma. Astrocytoma is the largest group of brain tumors. It may be benign or it may be malignant. So far, the location is concerned, it happens to be supratentorial in 75% cases. It may involve cerebellum, but in 35% of cases. And so far, the brain stem is concerned, astrocytoma involve the brain stem in 15% of cases. WHO classifies astrocytoma in four groups. Group 1 tumor would be called as the pilocytic astrocytoma, usually seen in pediatric age groups, and it mainly involves the cerebellum, it mainly involves the optic nerve, or it may also involve the hypothalamus. So these the three areas pilocytic astrocytoma or grade 1 tumor can be seen. So far, grade 2 is concerned, it is called as diffuse astrocytoma. Diffuse astrocytoma usually seen in younger age group. The prognosis is very good. It involves cerebral hemisphere, and as I mentioned that this usually involves the younger group with a very good prognosis. But mild degree neurological deficit can also be seen in grade 2 or diffuse astrocytoma. Grade 3 would be called as anaplastic astrocytoma. There will be increased mitotic activity, there will be increased anaplastic activity, but there will be no necrosis. So this is what the distinguishing feature between the third and the fourth is. The fourth is glioblastoma multiforme. Glioblastoma multiforme, or in other words, in short, we can call it a GBM. GBM happens to be very malignant with very poor diagnosis, and the hallmark is necrosis. So if there is necrosis, this would definitely be glioblastoma multiforme. Glioblastoma multiforme is usually seen about 65 years of old, or in older age group we can see GBM, we can see GBM. So far its radiological presentations are concerned and features are concerned, this consecutive slides will show you how we will be able to appreciate the grade 1, grade 2, grade 3 and grade 4. So let's start these images. On this axial CT images, you can appreciate that there is a posterior cerebellar lesion. This is on the left side of the cerebellum, cerebellar hemisphere. This is predominantly cystic lesion, and within the cystic lesion you can appreciate there is enhancing mural nodule. Because of the space occupying, it is resulting into hydrocephalus. The one point is there is no surrounding edema. The differential from the medulloblastoma would be that there is no edema, while in medulloblastoma you can see there will be edema. Both are with the same location, but if astrocytoma, pilocytic astrocytoma grade 1 tumor, if appears within the cerebellar region, it will be called as cerebellar pilocytic astrocytoma. According to the WHO classification, this would be classified as benign, as grade 1, and here it will appear on the CT images, post contrast CT images with an enhancing intramural nodule. On this non-contrast axial CT images, you can appreciate in the right cerebellar hemisphere there is a well-defined predominantly hypodense lesion with increased intramural nodule. I would say here that the lighter hypodensity is of tumor type, and greater hypodensity would be of a mural or nodular type. So far the surrounding edema is concerned, you can't appreciate surrounding edema in that case, and beside this it will also lead to the hydrocephalus. So this is what cerebral pilocytic astrocytoma would appear on the CT axial images. Again, a very classical example of the cerebellar pilocytic astrocytoma involving the cerebellar right cerebellar hemisphere. Again, you will appreciate that this is a well-defined hypodense cystic lesion. having intramural nodule which is enhancing post contrastly. So far the surrounding edema is concerned, there is no appreciable surrounding edema in that particular case. So this is what the cerebellar pilocytic astrocytoma, and the differential you always keep within your mind, that would be medulloblastoma. That would be its differential. On this CT axial image, you can appreciate that there is an ill-defined lesion involving the right-sided parietal lobe, and this happens to be a hypodense. It may appear as an isodense, or sometimes it may appear as an hypodense, as in that case you can see that this is an well-defined hypodense with minimal midline shift is also visible. It because of the contact blood brain barrier, there will be very poor enhancement if you give contrast to this patient. Another example of diffuse astrocytoma involving the left frontal lobe. This is again a well defined hypodense lesion. In that case there is no calcification, however midline shift is there, surrounding edema is also visible. So because of the blood brain barrier intact, so you cannot see properly enhancement in that case. So this is what the diffuse astrocytoma will look on the CT images. Here on this case, this CT axial image, you can appreciate a well defined diffuse astrocytoma below the, what I would say, Salvian fissure. And Salvian fissure is the demarcation between the frontal lobe and the temporal lobe. So I would say here it is in the temporal lobe. Lesion happens to be a hypodense, and there is a surrounding edema as well, and on the contrast it will not give rise to a proper enhancement. Well, as you know that the diffuse astrocytoma is graded as grade 2 by WHO classification. Here in that case this is not the grade 2 or diffuse astrocytoma. This is what actually is a cerebellar pilocytic astrocytoma of grade 1. This is the example of grade 3 anaplastic astrocytoma. This is more extensive, you can see more infiltrative, and you can see there is a significant peritumoral vasogenic edema. So this is what the characteristic of anaplastic astrocytoma is, which is involving the left frontal lobe. So this is what more infiltrative or extensive nature associated with vasogenic edema, and on contrast enhancing imaging it would not be enhancing. So this is what anaplastic astrocytoma look on the CT images. Again another example of diffuse astrocytoma, which is grade 3 according to the WHO classification, happens to be a hypodense with extensive infiltration in that case, and with peritumoral vasogenic edema causing compression onto the lateral ventricle and causing midline shift, particularly in that case is resulting into the contralateral hydrocephalus and prominence of the anterior and posterior horn of the lateral ventricle. This is anaplastic astrocytoma grade 3 of WHO classification. A few examples for the better understanding of the anaplastic astrocytoma of grade 3 WHO classification. As I explained it, it is extensively infiltrative with a high vasogenic edema which is visible on these images. GBM or glioblastoma multiforme happens to be a very aggressive lesion, and there will be a contrast enhancement, and there will be a vasogenic edema much more extensive than the anaplastic astrocytoma, and in that case you can appreciate this is involving the frontal lobe, and surrounding halo can be seen, a surrounding ring you can appreciate, and this is one of the important feature of the glioblastoma multiforme, that this would be called as a ring enhancing lesion. What I would comment on this axial CT images would be that there is an extensive lesion, infiltrative lesion with strongly vasogenic edema and ring enhancement, causing compression to the ventricular system and also causing midline shift. Anterior horn of the lateral ventricle is compressed. On the contralateral, there is associated hydrocephalus can also be seen, as it is a very extensive and very infiltrative lesion with a very poor diagnosis. On these images, both upper and lower, and both in axial and sagittal images, you can appreciate that there is a glioblastoma multiforme, highly extensive lesion, infiltrative lesion, and contrast enhancement can be seen. You can also appreciate the vasogenic edema. It's more extensive as compared to anaplastic astrocytoma. All the infiltrative features can be seen. Midline shift is there, causing compression to the anterior horn of the lateral ventricle. Contralateral ventricle is dilated, causing hydrocephalus. So this is what the feature of glioblastoma multiforme on CT images. Another example of GBM involving the right-sided frontal lobe with an infiltrative behavior, with a strong vasogenic edema, with an enhancing pattern. So this is what the glioblastoma pattern would be on the CT images, and in first go you will immediately recognize that this is very extensive, very infiltrative lesion, causing midline shift and causing compression to the surrounding structures. So astrocytoma and its multiple grade has been discussed. We have discussed and shown you the grade 1 benign pilocytic astrocytoma or cerebellar pilocytic astrocytoma. Grade 2 has been discussed, and the feature of the diffuse astrocytoma was quite clear to you on the images. Grade 3 with the anaplastic behavior, anaplastic astrocytoma with increased mitotic and anaplastic activity was there, and in the grade 4 glioblastoma was also present, and you have shown all these cases over there. I do hope this would be a very useful video for you, and this would be a first layer of knowledge to understand about the 4 grading of the WHO regarding the astrocytoma. It's not much difficult, quite easy. Always keep the age and the location of the lesion, age of the patient in mind, and the location of the lesion in view. This will help you towards a correct diagnosis. So I do hope this would be worth watching. Keep watching my video and keep sharing, and always watch 2 or 3 times to make it fix and to make it penetrated in your in your brain tissues. So some other videos will see each other. Till then, take great care of yourself.